Thank you for the introduction, and thank you, Nutrition, for inviting me to speak today. I will do my best to keep you entertained and awake during the postprandial slump. Fantastic lunch, Nutrition. It was very, very good. I'm sure you'll all agree. So we're going to whiz through a little bit about stroke. So we'll be looking at optimizing nutrition and hydration in the stroke population. And during this session, we will look at the evidence base around how nutrition and hydration impacts outcome. We will look at how it's assessed, how we monitor and what causes dehydration and malnutrition, and then we'll look at some interventions through food fortification, oral nutrition support, and to enteral tube feeding, and hopefully some time for some questions at the end as well. So we have to kick off with malnutrition, which, as the dietitians amongst you in the room will know, and many of the speech therapists as well, is defined by Elia here in 2003. Basically, either too much of, not enough of, or an imbalance of one or more nutrients. So your nutrients being fat, carbohydrate, protein, etc. But the important bit here is that it causes measurable adverse effects on tissue, body form, function, and clinical outcome. So what that means is that a lack of protein may result in reduced muscle mass, which then may go on to have an impact on function. So reducing functional decline, mobility, rehab, etc. in the stroke population. And actually what we're really interested in is undernutrition. And undernutrition is defined by BAPEN as a body mass index of less than 18.5, okay? But on its own, that isn't necessarily a problem because there are many people who live very healthily with a BMI of 18.5 or less. But then it's combined with this unintentional weight loss of 5 to 10% with 3 to 6 months, okay? We know the prevalence of malnutrition is pretty varied, and you'll see the Foley paper from 2009, what they actually do is look at many different studies as part of their systematic review, and they find this range between 6 and 60, which is huge, isn't it? How can we possibly work with a range between 6 and 60? The reason for that is that many of the studies don't necessarily use validated screening tools. Many don't use screening tools at all, and it's very subjective in terms of clinicians saying this patient is at risk of malnutrition or not. Nationally at the moment, with some of the SNAP data, which is the Stroke Sentinel National Audit Programme data, around about 20% of patients admitted to stroke units are at risk of malnutrition when they're in hospital. We know that a quarter of patients go on to become more malnourished in the first week following their stroke. So you've got this population of patients who are admitted at risk, and then a further quarter who go on to become more at risk for many reasons, which we'll talk about as we go through. Malnutrition is an independent risk factor for mortality and poor outcomes. And we'll look at a couple of papers that summarise that. Patients who are malnourished following stroke are more likely to die quicker, to be in hospital for longer, and to cost more. This study that we've got on the screen now by Gomez and colleagues, this is from last year, where they looked at nearly 550 patients admitted consecutively to 2 stroke units in South London. And what they looked at was nutritional risk when they came in. So they used a validated screening tool, i.e. either MUST, which some of you may be familiar with, or local screening tools used in those hospitals, and then linked that to nutritional risk and then to nutritional risk and then outcome, length of stay and costs. And what we can see on this little slide here is that we've got your low risk group, your medium risk group, and your high risk group, as categorized using the nutrition screening tool. Those patients who were at medium risk, the risk of mortality here at 6 months was nearly 4 times greater. And for those patients at highest risk of malnutrition, nearly 6 times more likely to be dead at 6 months when compared to patients who were adequately nourished on admission to hospital. And that's a really important finding. And this is adjusted, let's remember, for these co-founders as well, and in particular stroke severity. So what that means practically for you guys is that if you get 2 patients admitted to your stroke unit with similar deficits, similar stroke, similar symptoms and signs, if one of those patients is flagged as malnourished and the other one isn't, the one that's flagged as malnourished is more likely to have poor outcomes, more likely to die quicker, by 6 times more likely to die at 6 months, which is pretty incredible, really. They then went on to look at length of hospital stay and found that patients at the highest risk of malnutrition were more than 3 times more likely to be, or length of stay rather, was 3 times longer, and hospital costs were significantly more as well, which you would expect with that associated increased length of stay. We go on to look at dehydration, and dehydration is something we talk a lot about in clinical practice, but in terms of diagnosing it and defining it, it can be quite challenging. Commonly used methods, which many of you may be familiar with, are things like monitoring fluid intake. Okay, so those of you in the room who've looked at fluid balance charts in the acute setting or in the community may well know, but they're not always as accurate as we would like them to be. We may ask patients about dry mouth or thirst, look for oral thrush, those sorts of things, but again, there are limitations with that. We may look at urine colour or volume. Patients who are catheterised, it's easy to see the colour of the volume, but the colour of the urine rather, but again, that may have limitations. Blood pressure can decrease with dehydration, heart rate increasing, and looking at urea, creatinine ratio, or plasma osmolality, serum sodium, renal function, etc., are all possible methods for assessing dehydration, but they all have their various limitations. And this Cochrane review by Hooper et al. Found that no one test was consistently able to pick up and diagnose dehydration. So it's probably a combination of some of the observational clinical factors such as dry mouth and thirst, blood pressure, etc., but then also combined with some of the biochemical markers. A nice study looked at this from Scotland, where they looked at 2,500 stroke patients between 2005 and 2009 across 2 hospitals. They defined dehydration as a urine creatinine ratio of greater than 80. And they looked, like I say, quite a large sample size, 2,500 patients, and what they found was that 36% of these patients admitted to stroke units were dehydrated on admission. Okay, and then a further 26% who were not dehydrated on admission went on to show at least one sign of being dehydrated during their hospital stay. So in total, 62%, nearly 2/3 of patients on these stroke units were at some point during their admission recognised as being dehydrated. Okay. So then they looked at risk factors for that. So what was causing these patients to be more dehydrated? And this is really useful for us as clinicians to recognise when these patients come through the door or when they're referred to you to look at some of these risk factors. So not surprisingly, age. So older patients were at greater risk of being dehydrated. Females were at greater risk of being dehydrated, perhaps due to changes and differences in body composition compared to males. The more severe strokes were at greater risk of dehydration, which you would expect because often dysphagia is associated with, or dehydration is associated with dysphagia, difficulties feeding oneself or visual or cognitive impairment that you may see with the more severe strokes. If patients were prescribed diuretics, so your furosemide or spironolactone, for example, for heart failure or other conditions that may need to reduce the fluid on board, and if they've been receiving parenteral fluids and enteral tube feeding. So those are the risk factors, and then they looked at outcome and actually what happens. And in dehydrated patients, dysphagia was prevalent in 56% of patients with dehydration versus 30% of hydrated patients. So dysphagia is a big risk, isn't it? And that was significant at 0.001. So 56% of patients dehydrated versus 30% those were hydrated. And looking at mortality or discharge to institution, 43% of patients who were dehydrated versus 18% of patients who were hydrated. So if you're dehydrated, you're going to have poor outcomes, you're going to be in hospital for longer. And then what this paper does is nicely looks at both of those 2 areas. So how many people in the room are familiar with SNAP, with the Stroke Sentinel National Audit Programme, Working Stroke? Fantastic. Good show of hands there. So you'll be familiar with the questions. The speech and language therapists in the room will be familiar with the 45 minutes of therapy time and the swallow screens, etc. The dietitians in the room may be familiar with nutritional screening and whether they were seen by the dietitian or not. And what this study by Bray in 2013 looked at was looking at some of these processes of care associated with SNAP. Okay, so some of these assessments, such as did the patient receive a CT scan within X amount of time? Were they seen by a stroke consultant? Were they admitted directly to a stroke unit? These sorts of things, and then looking at processes and outcome. Okay, and what we can see here is, apologies for the font, is if they were seen by a stroke consultant, it had a significant impact on 30-day mortality. Okay, if they had a brain scan within 24 hours of admission, there wasn't significance at outcome at 30 days. What they did was they combined bundles. So rather than doing individual processes, they combined a few different ones. So here, bundle 1, we've got what they've seen by a nurse and a therapist within 24 hours, and all relevant therapists within 72 hours. Again, didn't have an impact on outcome on mortality at 30 days. Bundle 2 is around nutritional screening and a formal swallow assessment within 72 hours, and that did have significant effects, perhaps due to rates of aspiration pneumonia being reduced in patients who are having swallow screens. Bundle 3 looks at whether they went to a stroke unit, first of all, and that didn't have an impact. But interestingly enough, Bundle 4, which looks at antiplatelet therapy, appropriate nutrition and hydration, out of all of those interventions, had the largest impact on mortality at 30 days. Okay, and in this study, what they looked, so in terms of hydration, they were talking about if a patient got greater than a litre of fluid within 24 hours, and the nutrition, again, was fairly subjective. But nonetheless, that's an interesting finding that nutrition and hydration in combination with antiplatelet therapy had the largest effect out of these interventions on mortality at 30 days. So I think this is the time where we reach for our keypads, folks. So if you've got those handy, we'll be using those very shortly. What I'm going to do is show you a couple of pictures of patients, and I want you to tell me if you think they're malnourished or not, okay, or at risk of malnutrition. So we've got patient number 1, and some of these are easier than the others. Patient number 1. Let's have a little look. I'd be surprised if we didn't we'll get this. Yeah, absolutely. Okay. A couple of people nodded off after lunch and nudged the no button there. So yeah, absolutely. Patient at risk of malnutrition. The sort of patients that we would see in hospital where we work? Yes, no, potentially. Maybe not that extreme, but maybe not far off at times. So patients malnourished, yes. Is this a process that's happened over a short period of time or a long period of time? Yeah, so is it in the hospital or in the community? Yeah, so a way of breaking that down, so community-acquired malnutrition in this case. The other way of thinking about it is it related to a disease state or is it related to psychosocial issues? And what would your thoughts be on this? Or a mixture, couldn't it? It's difficult to know from a picture. So disease states could be inflammatory conditions, COPD, we could have stroke, cancer, psychosocial patients living on their own, low in mood, drinking too much, not looking after themselves, living in isolation, that sort of thing. So it's a useful way of breaking down malnutrition. Community or hospital, and then disease or psychosocial, or a bit of a combination of all of them, because ultimately that will impact how we treat and look after these patients in the longer term. So patient 1, yeah, pretty good, guys, well done. Patient 2, what do you think? At risk of malnutrition. Okay, interesting. So a little bit more uncertainty with this one. So in terms of our definition of malnutrition being an excess or an imbalance, we could say, yeah, absolutely. So an excess of energy, yeah, to cause obesity. Thinking in terms of undernutrition, which is when we talk about malnutrition in hospitals, is really what we're thinking about. Would this patient flag up at nutritional risk on admission to our stroke units? No, she wouldn't. She's not got a BMI of less than 18.5. And we'll assume that she's not lost that 5 or 10% body weight in 3 to 6 months before coming in. What sort of weight do you think this lady is? Kilos? Who's got the loudest voice? 150. Yeah, so say 150 kilos. So do you think that we would notice if this lady lost 15 kilograms during her lengthy hospital stay by looking at her? Yeah, so probably not. So so the point I'm trying to make is that eyeballing patients isn't necessarily enough, and that we need to make sure that we screen everyone. So not just those patients like our first gentleman who's clearly malnourished on admission, but recognising that everyone is at risk of becoming malnourished. Because when people lose weight when they're stressed, what do they predominantly lose? They lose muscle. Okay, and any therapist in the room will talk to you about how difficult it is rehabbing patients who are overweight or obese with reduced muscle mass. Okay, it can be very, very challenging. So the point, like I say, I'm making is around screening, okay, making sure that all patients are screened for risk of malnutrition on admission and then weekly thereafter, okay, and eyeballing is not enough. The example I put on the screen is quite extreme, I appreciate that, but I was trying to illustrate that we need to make sure we're screening everyone. People who are flagged as at risk need to be referred to appropriately trained healthcare professionals, i.e. your dietitians. And the MUST screening tool from the Gomez paper has been validated in the stroke population, which we were lacking a validated screening tool in that population prior to that. We've talked a little bit about SNAP. The two SNAP questions that relate to dietetics is around screening. So proportion of patients screened on admission, a portion of patients screened during their admission on a stroke unit. And you can see that nationally we do pretty well with this one. The question is just, were they screened at any time during their admission? So certainly that could be tightened up, but it's encouraging that patients are being screened. And then the second point is whether they were then went on to be referred to dietitians or not. And again, you can see that 80% of patients screened at risk of malnutrition were referred to dietitians, and this is nationally in England, Wales and Northern Ireland over this time. You can see improvements since December 2013 to the present day, but still 1 in 5 patients who need dietetic input aren't receiving it. So in terms of malnutrition and dehydration to a respect, the main causes are either reduced dietary intake, so patients are eating less for a number of reasons, or they're eating and drinking well, but they have increased nutritional needs, which are then causing them to lose weight and become malnourished. Post-stroke dysphagia, as I'm sure you've heard this morning, is associated with increased risk of malnutrition. Okay. And in acute stroke, the prevalence of dysphagia has been reported, again, this wide range between 28 and 65%, based on how it's assessed and what time it's assessed during their stroke admission. But we know that dysphagia generally improves significantly during the early days, and by about 2 weeks post-stroke, 90% of patients are able to swallow safely. But that still leaves 10% who are struggling, and some of those go on to struggle even longer than that. Dysphagia is associated with increased mortality, morbidity, and institutionalization, okay, in part due to aspiration, pneumonia, and also this link to malnutrition and dehydration. A systematic review by Foley in 2009 looked at 8 papers looking at malnutrition and dysphagia following stroke, and they found that dysphagia was reported in 24 to 52% of patients who were malnourished, and that overall dysphagic patients were more than twice as likely to be malnourished than those who could swallow safely. So an important point, a red flag for the speech therapists in the room, the dietitians. As soon as we're making recommendations about modified diet or thickened fluids, putting patients nil by mouth, that increases their risk of malnutrition. And we know that increased risk of malnutrition and dehydration reduces outcomes and increases mortality. So some factors here. I won't go through all of these, and again, many of you will be familiar with them, but it's useful to break them down into the physical barriers or factors impacting oral intake. We've talked about dysphagia, but there are many other physical symptoms following stroke, such as patients becoming drowsy, hemiparesis or hemiplegia, patients unable to feed themselves, visual impairment, be it hemianopia or cortical blindness following stroke, cognitive impairment, which may be pre-existing or may be new, pain, GI symptoms, thinking about other comorbidities, so such as diabetes, and a number of our patients will have diabetes because it is a risk factor for stroke, making sure that we maintain good glycemic control. So the nursing staff, when they write down blood sugars of 15, 18, 20, that increases the patient's risk of both dehydration and malnutrition. So it's making sure that we get tight glycemic control to improve outcomes there. Psychological factors as well, obviously depression, anxiety associated with stroke, but a number of pre-existing conditions as well, and organisational. So there's no point having these fantastic clinicians that work very, very well at producing individualised care if at an organisational level we're not up to scratch. So making sure that we've got good ways to identify patients who need feeding assistance, that meal times are protected, the environment is adequate, etc. Thinking about the hospital food as well, where you work, or those of you in the community, the food that's prepared for patients at home, making sure that it's adequate and that patients are going to be able to meet their nutritional needs. Okay, so thinking about the environment, and the ward is not always the best place to eat and drink. You wouldn't take your loved ones there for dinner necessarily, so making sure we improve that as best as we can. Like I said, making sure meal times are protected, so we haven't got people being wheeled off for unnecessary investigations or therapists intervening at this time. That we've got an identified method for recognising patients who need assistance feeding, be that red tray or traffic light trays, which some acute trusts use, and using mealtime volunteers, or making sure there are ways that we've got enough pairs of hands on the ward to feed those patients. But we could have patients who eat and drink very well, there's no issues, but they're still at risk of becoming malnourished and losing weight. And that could be because they have increased nutritional needs. Okay, so patients with a diagnosis of ischemic stroke have a modest increase in metabolic rate and their energy requirements going up by about 5%. Okay, if you have an ischemic stroke, that increases to about 30% increased stress factor. So again, a red flag for everyone in the room. If you've got two patients lying in bed, one with a hemorrhagic, one with an ischemic stroke, that patient with the hemorrhagic stroke is at greater risk of malnutrition. Okay, so even if they're eating adequate amounts, their energy requirements may be up to 30% greater than at resting without any stress, whereas ischemic stroke may only be about 5. Okay. Looking for fever, infection, inflammation, so aspiration pneumonia can be common after stroke. If patients have open wounds such as pressure sores, malabsorption or increased losses through vomiting, diarrhea, high output stomas or fistulas can also increase nutritional needs and the risk of malnutrition. I'm thinking about energy levels as well. So working closely with your therapist to look at how active they are. What are they doing in the gym? What are they doing in the bed? What are they doing if they leave the ward? Or are there underlying medical conditions that exacerbate that? Parkinson's that's poorly controlled, patients with dementia who wander, taking into account these other clinical conditions. So how do we tackle the problem? So this is where we try and get a bit practical. We've got simple interventions and those that are more complex. Okay, so simple interventions is around dietary counselling. So encouraging patients, giving them permission to eat a little bit more. Okay, having larger portions, having food between meals, having double puddings, this sort of thing. Looking at the type of foods that they're eating, encouraging patients to eat protein-rich foods first rather than the vegetables, for example. We then go on to look at food fortification. And on the screen here, we've got some examples of methods of fortifying food. And it's a good starting point for those of you in the room who are faced with patients who are at risk of malnutrition and don't necessarily have access to some of the more complex interventions. This is a good place to start in terms of some of the advice that you can offer to patients. A nice way of summarising it is to think of your mashed potato and the budding chefs of you in the room who make your mashed potato. How do you make that extra tasty and nice? What do you add to it? We add butter, we add cream, we add milk, we add, yeah, exactly, cheese. So the scoop of mash is the same size, but in terms of nutritional content, it's far, far better, isn't it? So that's what we mean by food fortification. Okay, so same portion of food, but just far more nourishing. Then go on to look at modified diet. So again, we know that as soon as patients are placed on modified diet, that's a big red flag in terms of dehydration and malnutrition. Our aims are trying to reduce that, to minimise aspiration pneumonia and to maintain oral intake for quality of life, for comfort, for dignity. Okay, but we know that texture modified diets are often inadequate. There's this study by Wright in 2005 that looked at 55 inpatients on an older person's unit, so not necessarily a stroke unit, in a central London hospital, and they did weighed food intake. So they weighed all of the food that got given to patients on the ward and then weighed all of the food that came back, so to see how much they'd eaten. And they looked at food charts as well and split them into two groups. So 25 patients were having normal diet and 30 were having modified diet. And what they found were that those patients on the modified diet group were consumed less than 40% energy and protein, which is huge amounts, isn't it? So 40% less energy and protein if someone's on the modified diet. It's not a huge sample size, but it's a nice trial just to clarify that those patients are more likely to have less energy and protein. So the speech therapist amongst you, when you put your sheets behind the bed saying puree diet or thickened fluids, mashable diet, etc., just to recognise that those patients are going to struggle to eat and drink enough and to meet their nutritional needs. So giving your dietitian a nudge next to you and saying, guys, you might want to get involved and have a look at this patient. Only 13% of the modified group even finish their meal. Okay, so it's a big red flag, modified diet. Reasons for that, so it's reduced choice. Those of you working in the acute setting, you'll know that the hospital menus have less option and variety for puree diets versus regular diets. Okay, how it's presented and how palatable it is. So there are many meals out there now which you can make with molds. So the peas and the meat and fish example, for example, look like peas and meat and fish, but we still see from time to time food being mixed up together, which looks very unpalatable. Making sure that nutritionally it's adequate. So as soon as we start adding lots of fluid to dilute and puree our foods, we increase the risk of of poor intake and of malnutrition and of dehydration, and that these patients may need supplementary tube feeding and or oral nutritional support. In terms of thickened fluids, again, patients on thickened fluids, as you know, are more likely to drink less. A study by Whelan a few years ago looked at inpatients with stroke, split them into half receiving powder thick or half receiving pre-thickened drinks. And what they found was that people in the thickened fluid group managed less than 500 mils a day. Okay, so when thinking about fluid, what we work on requirements-wise is for patients who are under the age of 60, looking at 35 mils per kilogram body weight, and for patients who are over the age of 60, 30 mils per kilogram body weight. So your 50-kilo lady who's over the age of 60 needs about 1.5 litres of fluid a day. So what this study showed was that patients on thickened fluids were quite a way away from meeting that. Okay, but patients on pre-thickened drinks drank almost double that. And a study by Vivanti found that patients actually got more fluid from their food than they did from their pre-thickened drinks, from their thickened drinks. Okay. Different types of thickeners out there. So the gum-based and the starch-based. Quick show of hands, who's using more gum-based out there now? Yeah, and the starch-based? Okay, so gum is starting to take over, which is encouraging because all the anecdotal evidence and indeed the evidence out there is that patients prefer it. They drink more with gum than they do with the starch-based thickeners as well. And in terms of optimizing that, if we give people a tin of thickener, let's give them some squash. Thickened water is not very palatable. The gum-based ones are better because they're better for thickening milk and soups and supplements compared to the starch-based. So that, again, can increase nutritional intake as well, which we know is very important. But it's getting the systems in place, having that collective approach for minimizing malnutrition and dehydration, whereby we are giving whoever visits the patient, be it the consultant, the physio, the dietitian, the speech therapist, the nurse, the volunteer, we're all encouraging patients to drink and to eat because we know that patients don't eat and drink enough and that will affect outcome. Quick look at nutritional supplements as well. So the evidence around nutritional supplements in stroke shows that nutritional supplements significantly reduce pressure sores, increase energy and protein intake, but there is no significance in terms of death, dependency, or length of hospital stay. Now, many of the studies used in that Cochrane review have been criticised in terms of their methodology, and there's a wide range of heterogeneity in there. And they conclude that supplements may show benefit in those who have signs of malnutrition. And that's supported by a Cochrane review by Milne in 2009 in older people, that those who are at the greatest risk of malnutrition will have the greatest benefit from supplements, but not to routinely prescribe supplements to anyone. Okay, and that we should initiate nutrition support, be that tube feeding and or nutritional supplements. In terms of different styles of nutritional supplements, there are obviously milk-based, our typical 300 calories and 12 grams of protein, or juice-based, which may have similar amounts of energy but reduced levels of protein, yogurt, dessert, or savoury, which may be useful for patients with requiring modified diet. Liquid is probably most common, but there are powders, protein or carbohydrate powders that may be added to food or drink to help with that. And pre-thickened drinks, so they're very well tolerated in patients who are requiring stage 1 or 2 or 3, who instead of having thickened drinks are actually having the pre-thickened nutritional supplements have better tolerance with those. Energy and protein densities vary. So as a general rule, what we're thinking about in terms of protein is about 1.2 to 1.5 grams of protein per kilogram for older patients while they're unwell in hospital. Okay, so again, our 50-kilo lady is going to need somewhere between, 60 and 75 grams of protein in a day, which is quite hard to meet in some cases with the barriers we've talked about in hospital without the use of nutritional supplements. Gastrostomy or NG, we know that gastrostomy is associated with fewer feeding failures, so tubes are more likely to stay in and not get blocked so easily. Therefore, patients get more feed. There's fewer incidents of GI bleeding and fewer pressure sores. But there's no significant difference in terms of mortality between whether we put a nasogastric tube or a gastrostomy into a patient. No difference in dependency or length of hospital stay. And interestingly enough, no difference in chest infection or pneumonia. Because anecdotally, often you have members of a team talking about putting a peg in to reduce the risk of aspiration pneumonia. These Cochrane reviews suggest that that isn't necessarily the case. But starting tube feeding early after stroke may reduce death. Okay, so which leads us on to our guidelines. So early NG feeding, if patients in nil by mouth, get the NG tube in early, so within 24 hours. There are obviously exceptions to that if patients are palliative care or if patients have just been thrombolyzed. There are some units that like to wait to 24 hours before putting tubes in people. And if patients pull out tubes, to think about nasal bridle or other options to secure tubes. Contraindications for NG are, in terms of thinking about which patients we put them in, patients with raised INR or reduced platelets, so clotting issues, we would be mindful of, and patients who refuse, obviously insertion as well. And complications, the biggest complication is patients pulling tubes out. As I'm sure you're all aware, up to nearly half of patients will dislodge nasogastric tubes at some point, which leads us on to our next little point now is around how do we keep nasogastric tubes in place. Okay, so this is looking at nasal bridles, and again a study that was found that nasal bridles are actually pretty effective compared to tape at keeping tubes in place, and found that the intervention group of bridles had 17% more feed than those who just had tape. But interestingly enough, the amounts were still quite small, so still only 75% of feed was received, even with a bridle, versus 57% of feed without a bridle. So patients without a bridle are obviously at increased risk if tubes are coming out. Gastrostomy feeding, just very quickly before we finish up now, is recommended for patients who are struggling to swallow or manage adequate amounts at 4 weeks, or that they're at long-term high risk of malnutrition. Contraindications would be previous gastric surgery, for example, ascites if they have alcoholic liver disease, if they're, again, the patient refuses, or if they have clotting issues, and a number of other areas. Complications tend to be initial after PEG. So the first 72 hours, risk of peritonitis, risk of leaking from around the PEG is increased at that point, and that can be very serious and can increase mortality. Which moves us on just to some of our key learning points. I guess the takeaway messages are that malnutrition and dehydration increase mortality and poor outcomes, that post-stroke dysphagia increases this risk. We need to screen. Those patients who are unable to manage adequate amounts or in nil by mouth should have an NG within 24 hours, and that patients receiving modified diet are increased risk and need to be assessed and reviewed appropriately with the use of oral nutritional supplements, enteral tube feeding, and or intravenous fluids, and that patients who can't swallow should be considered for gastrostomy at 4 weeks, and that ultimately high quality nutritional care is underpinned by a multidisciplinary approach, which is why it's great to see so many dietitians and speech and language therapists here today working side by side, and also the rest of the MDT, a collective approach so everyone is offering food and drink and being involved, and adequate staff knowledge and skills. Thank you.